We are excited because it's now a lot of achievements have been registered. So our session is going to be chaired by our own Commissioner of Health Services in charge of emergency health services, emergency medical services. Dr. J.B. Wainai is here with us. Is going to chair this session. Dr. J.B., you are most welcome. Please, the audience is here. We have the audience online and also on YouTube streaming live, and of course this physical audience. So J.B., you are most welcome to take over until break tea. Thank you. Let's give him a welcome hand clap as he comes to steer us to the next session.
Good. Thank you so much, Bwana Basajja Tebadiba. As introduced, Dr. Wanyai John Baptist. I'm Commissioner for Emergency Medical Services at the Ministry of Health. I'm going to take you through this morning session. We were to start immediately at 9:20, but we gave it some time to 9:30. And I'm happy to register that our two presenters are with us, and we shall not waste a lot of time. We shall set ourselves going. The first is going to be Professor Handa, and he will be followed by Dr. Esther. I will pass through. Sorry, sometimes my voice, when it is this AC, sometimes I react, and so I may get some few issues with my voice, but I ask you to bear with that. I'll give you some background, and before this, I want to thank all of you who have managed to turn up this morning, and also appreciate the team which is attending virtually, which is quite good. Today we have Professor Handa Yujiro. Professor Handa, I think most of you, when you look at him, you'll be able to remember. He has been with us. He's a specialist in the field of hospital management. While he first had his initial training as a dental surgeon, and later on he specialized in oromaxillofacial surgery and practiced in Japan and Germany for many years. After 12 years of hands-on clinical practice, he started to work with the operational theater management in 1986, and later hospital management, particularly on the 5S Kaizen T2M framework. As an advisor to JICA, he was stationed in Tokyo, Colombo, and Nairobi, and visited many countries in South Asia, the Middle East, and the African continent, working with hospital management and Ministry of Health officials to uplift quality, safety, and efficiency of hospital services through infrastructure and workplace improvement. He is a visiting professor at the Global Health and Health Security Master's course of Taipei Medical University in Taiwan. Currently, Professor serves as a senior consultant on hospital management and patient safety at health ministries of Egypt, Ethiopia, and Uganda. And with that, allow me to invite Professor. He was here very early, I think on the dot of 9 a.m. And I want to take this opportunity to welcome you, Professor, to join and give us the package which you have prepared. Thank you. Please, a round of applause to welcome Prof.
Good morning, ladies and gentlemen, and important delegates from all over the country. And I'm very happy to be here as one of the speakers in order to share very useful and important conceptual framework related to hospital management. Today's focus is innovations. This is not an easy task for me to talk about innovation, but I do my best, and I want to share even difficulties and also advancement in recent years in Uganda and also in other countries, including Japan. So innovation. What is innovation? This is the starting point. Let's start my presentation. Okay, this is me. This is me, yes. It's a little bit of fake photo. It has taken 5-6 years ago, but I'm not so changed. We are both a country with attractive country symbol birds. Uganda have this particular bird. I like it very much, but this is not so easy for me to see this particular bird in the urban area in Kampala. But if I go out station, I have seen this particular symbolic bird of Uganda 3 times in the past. I'm very happy. Then the other bird in the right-hand side is a symbol of Japan. Then we also have a symbolic mountain, Mount Fuji in Japan, and also, is it Mount Elgon? Am I right? Elgon? Yeah, yeah. Both countries have a high mountain, and then also we are proud of them. So Japan and Uganda is a friendly country sharing the common symbolic natures. So I would like to start with a little bit of a conceptual matter. But as we are all a professional in this particular field of government healthcare, so I just quickly make a review of the conceptual matter and go into the details. So, ladies and gentlemen, this is a conceptual framework of the hospital management. We have 7 different layers. We have to start from the bottom. Then a lot of hospitals have a lot of efforts to do work environment improvement using 5S activity and try to go up to the summit of this particular mountain. Our goal is sharing the happiness and the healthy condition with the patient, a lot of patients and family member. In order to go up to the top, definitely we have to go up to the mountain step by step, and then 5th layer, we have 7 managerial targets. Among the 7 managerial targets, we have a very important 2 things, quality and safety. This is easy to discuss, but not so easy to practice. So, among the 7 different managerial targets, the most fundamental thing is the safety. Without patient safety, without safety for the medical staff, hospital staff, we can't achieve other targets. Cost control, quality improvement, improvement of the service delivery practice, and also the productivity of each health facility could not be achieved without patient safety and safety for the staff. So, having said that, what is innovation? Innovation in our context is a kind of additional specific function, favorable function to enrich our own healthcare. Although we have a lot of difficulty, particularly shortage of staff and shortage of resources, this is not a problem only for Uganda, but an international problem. Everywhere we have this particular problem. Even though we have to seek little by little, small and then impactful innovation. Innovation is additional specific functions to the existing routine work. So, specific function could be defined, as you can see on the slide. It's a kind of creativity which we need to create new effectiveness producing services, or endorse existing services with enhanced potential for creating additional effectiveness. Innovation should contribute directly or indirectly to the effectiveness of the healthcare. So, innovation should be given an impact to the entire health system. Health system is a very big one, including a lot of factors. I don't go to details of that here because we are professional on the consideration to the strengthening health systems. Well, expected the definition of the health system, just for the quick review, it's include the function of promotion and the maintenance of the health, as well as the compensation for permanent disabilities. I think this is very multifactorial system. So among our task routine services, we have to seek quality improvement. This is very common among common understanding among us. There are some elements of the quality, as you can see here. Then, for the betterment of the quality, okay, we recognize the 8 different fields of innovation. As you can see here, product and product performance, technology, and business model, organizational innovation and process innovation, marketing and sales, network, customer engagement. Those conceptualization is made in the business sector, as you can see. But we are learning from the business sector, then try to accommodate some elements to the government service. Government services, the first class objective is not earning money. The first class objective is to provide high standard healthcare to the general public. But we have to have a sense of the business-oriented mind. We can apply some in our government work. So, allow me to just introduce 1 or 2 examples. Product performance. We have a little bit of innovative change to the existing equipment, and then physical facility maintenance. And technology, we have to create our own frugal innovation. I will touch upon it later in details. As a business model is a cost recovery model, which you have already introduced. And then the organizational innovation, we can say that full-time safety quality officers in every health facility under the government. The process, yeah, we have a lot of things to do. Perfection in use of SOP or clinical pathways for every healthcare packages. New channel innovation, we can just strengthen referral and back referral activity in the community. I think those are the very well-known topic. Networking, hospital safety reporting system, which is now in our hand in relation to our project for uplifting the hospital-based patient safety activity. We have incident report system, but because of the name, I think a lot of staff is reluctant to send the report. So we proposed to change the name with a positive image, hospital safety report. We have to report a lot of near misses in order to prevent preventable death, preventable harm, a lot of things. We can do a lot of things, hopefully with a digital system. And then also, customer engagement is also important. Patients and family members, let's say community people, are our customer. Am I correct? If we agree on that, we have to involve them in terms of the further improvement of safety and quality in the hospital or health facility, regardless of size and category. Those are the fields which we can apply our innovation. We can add specific functions to the existing routine procedure. So, what is our focus? Foci, foci is the plural of the focus. English is not so easy for me. I learned the plural form. Foci for innovation in government health care. Our foresight could have given to patient safety. And in order to do that, we have to look into this particular mountain of hospital management framework again. If you want to improve safety, we have to look into 4 different countermeasures to create improved patient safety. Human resource, and then hardware, and the material, consumable and drug, and work method. Work method is a SOP, including clinical pathways. Those 4 different areas should be strengthened with the additional specific function, let's say innovation, our own innovation. So, if I focus to existing problem-solving activity at every corner of the hospital, which is called Kaizen in Japanese language, or continuous quality improvement, CQI in English, I think Kaizen activity is the key to success, to realize innovation. Innovation on human resource, men and women, innovation on machines, hospital equipment, innovation on materials, consumables, drug, in-house logistics, and then innovation in SOPs, clinical pathways, standardization of the care. The key is Kaizen. Conducting Kaizen in a regular basis, we can have innovative things, additional function, favorable function for the entire healthcare services at the hospital. So, quality of care, patient safety, innovation, total quality management, and Kaizen, and we have already conducted a lot of works in 5 S's. Those are interconnected. I really hope that you will reconfirm that. Everything is connected. So, what is the expecting innovation which we need for patient safety? Well, patient safety needs a lot of things, but I'm allowed to show 1 or 2 examples on that. Regarding the human resource, capacity strengthening of the health human resources, I focus one thing here, improving medical record system and practice. For that particular purpose, all doctors and core medicals have to write up the medical record with details using POS or SOAP, another thing. Those are one common thing, but the practice is not so easy. We have to make a system in every health facility to seek the perfection of the medical record system through capacity strengthening of health staff. So, machines, equipment, innovation. I want to introduce one interesting model. We call it the Cavalli Medical Equipment Management Model. They are doing a so-called total quality management in terms of the function of all different types of medical equipment in the hospital. Searching and mapping, assessment, then classification of the function and promoting preventive maintenance, and then budget planning. Those are interconnected, and then this is definitely we can call as innovative things as a managerial activity. We have seen a lot of managerial activity and then managerial innovation through 5S, Kaizen, and total quality management. So next, for materials, we observe the needs for drug reconciliation practice at admission of different types of patient. Patient use a lot of drugs outside of the hospital, then they bring those drugs into the patient ward. Nursing officer have to double check in collaboration with the pharmacy. Drug reconciliation mechanism could be installed in all different types of the hospital. This is a kind of innovation for us. Then, innovation related to the work method could be quality improvement teams management practice on SOP and clinical pathways formulated in all divisions. I expect much on that. All of the routine work could be standardized. For that particular purpose, standard operational procedures, or for the clinical topic, we need clinical pathways in every section of the hospital. The management could be done by QIT. QIT, Quality Improvement Team, have to have a thick file of the SOP and clinical pathways in the near future, and every time they can scan it and they can improve it, they can add it, and they can remove some unnecessary work. So those are the example of the innovation we expect. So strategies for creating innovation could be represented by this simple scheme. The important thing is a full participation. Innovation is created not only by top management and division head, but all of us should participate in the process. For that particular purpose, we have to make maximal use of the existing teamwork in every division, and then if the teamwork is not enough, we have to create that. Otherwise, we can't create an effective innovation. Even the team member or a team leader on the ground can have an initiative to have innovative things. Let's take a look at this picture. It's an ultrasound machine, old one and new one. If the new one is introduced, this could be one innovation. But in order to sustain this innovative change, definitely we need the support system. If the innovation is given to the hospital only once, then if they cannot do anything to sustain the innovation by 5S and Kaizen, the machine comes to be a burden easily to the hospital management. then, even though the innovation, first investment is very small, if the people conduct the 5S and Kaizen, you can just maintain the function of the innovation, and then they can continue a betterment of the quality of the service and safety as well. But still, we need investment. The improvement of the healthcare should be balanced improvement. Investment by the government, collaboration with the international and domestic partners, and then improvement of the managerial activity at every hospital, and improvement of the skill and knowledge and practice of the health staff. Those should be balanced. For that particular purpose, we try to do 5S and Kaizen, but even though investment by the government is repeated many times, if 5S and Kaizen is not enough, we will have a setback. This is really visible at every hospital, although the staff is doing their best. So it's good to have an investment, multiple investment, but they will have a setback. If you conduct 5S together with the innovation, definitely we can minimize the setback, as you can see here. Then it's very good, but still with a small setback. Only 5S is not enough. As an organization, we definitely have a capacity to have a problem solving using Kaizen or CQI. Kaizen is a problem solving for the benefit of staff and for the benefit of our client and patient. Staff could enjoy the easy and enjoyable, comfortable working environment, and also making maximal use of this benefit to make the staff positive to the patient-centered care, and then as a result of that, we can achieve quality of care. So, if you conduct definitely with if you conduct the 5S and Kaizen all the way through the multiple innovation, we will have a tremendous magnitude of change. As you can see here, the difference is a magnitude of improvement. Definitely, we need strengthening of this particular 5S and Kaizen support to the continuing repeated innovation. So, this should not be with us. Only one-time innovation, investment, and it becomes a burden for the hospital later. We have to avoid to do that. So I have to touch upon the frugal innovation. Allow me to introduce my own frugal innovation which I made in the past during my clinical time. Frugal innovation is a low-cost new product method or designs that have been created for or come out of what is known as the bottom of the pyramid of the unserved lower end of the mass. This is a definition stated in a business sector textbook. Frugal innovation is connected to appropriate technology, and appropriate technology could be utilized together with Kaizen. Everyone have the potential to a developer. I was not an exception. So you can see that during the World War II, United Kingdom used that kind of ambulance because they have a shortage of ambulance. That was a frugal innovation in that particular time, 1940 or early 1930 to 40. Still, we have a difficult situation. In other countries, they are using this kind of thing. This is a small innovation in Japan, nursing practice. The patient who cannot take a shower or bathing, nursing officer wash their patient body on the bed. This is a small thing, but it's an innovation. We have to improve the care by small innovation. Then you can see this. This is a very wise idea to wash hair on the bed. The patient, bedridden patient cannot go to the shower room. In that particular case, in Japanese hospital, nursing officer make a special pillow and then wash the hair using bath towel and plastic bag and one bucket. As you can see here, the patient can enjoy the hair washing supported by a nursing officer. This is also innovation, small innovation in a Japanese hospital in connection to safety. Avoiding medication error, they made this kind of hanging system of the fluid and double check system by 2 persons. This kind of thing is not expensive, it's easy technology. This is again a frugal innovation in Japan. This is developed in the orthopedic department. Lower extremities fractured case. It is very difficult to remove the pajama at examination. So they, a team of the orthopedic surgeon and nursing officer created this particular special pajama for the orthopedic patient injured in the upper extremity. You can just have an easy examination, easy treatment. So, I'm Professor Handa. When I was young, I was one of the developer of the frugal innovation. Allow me to show it. Handa wanted to minimize the postoperative sequelae. I was a maxillofacial surgeon. My problem of the postoperative lower lip numbness after lower jaw bone surgery. We have made a sagittal splitting osteotomy of the mandibular ramus. In that particular case, the bone cutting was done very close to the nerve. Then, as you can see here, in that particular time, the bone was not cut but separated by Meisel. Meisel is German word. What is the English word of the? A chisel. Yeah. We try to avoid that. Then, as you can see here, the problem was identified by our team. Postoperative lower lip numbness occurred due to nerve damage by bone saw or bone cutting procedure. So, I stopped using this kind of thick chisel and hammer. Then I made a small publication. It was very old, 1991. Are you was born 1991? I was born in 1952, so I was a young surgeon, and I created a standardized method of the measurement of the size of the bone. Then I made a design of the osteotomy line. Then I stopped using large chisel but using thin bone saw like this, and then I modified the procedure. But I forgot to name this modification Handa's method. In Japan, we didn't do that. Yeah. So by the modification, I could reduce the post-operative complication 10% to 2%. I have made around 70 cases. Yeah. Then this particular method is widely used all over Japan and Asia, but all people forgot me. That is a part of the reality, but I'm happy. I'm happy. So I could improve the safety and improve quality a little bit. So there are so many frugal innovation. There are so many things we can do. As you can see here, what is this? Clay pot. If you keep the water in clay pot, what happened to the temperature of the water? Yeah, we can drink a cool water. Someone created special refrigerator using clay. This refrigerator doesn't need any electricity. Am I correct? Then it could maintain 10 to 15 degrees centigrade lower than the room temperature. I think this is one frugal innovation. What is this one? This is a report from India. A lot of mothers have to be away from the baby if the baby was accommodated in the neonatal unit. Am I correct? Yeah? But baby needs breast milk. This is nutritionally or pediatrically, it's a correct thing. So in India, in some hospital, they had a system to collect breast milk from each mother and then store it and provide it to respective babies. This is one frugal innovation. This is only $1 product created for the patient of cleft lip and palate. Cleft lip and palate patient, I have already operated a lot of patients in the past, but they had a difficulty to swallowing. In order to avoid the pneumonia, aspiration pneumonia, the milk should be given in the right way. So someone created this kind of cup in India, again India. Then in Japan too, we do something. We ask the manufacturer of the artificial nipple to create a special size nipple for cleft lip and palate patient. This is a manufacturer, and then this is on sale at this particular moment. This is one frugal innovation of one of our colleagues. Then this is a very reasonable, this is a product with a reasonable price for avoiding the excessive bleeding after birth. The balloon tamponade to the uterus. This kind of thing is created by the medical team, and then this came to be a product available in the market. There are some products which it can be obtainable with a relatively low price, not necessary to purchase the luxury machine, but the simple and durable machine could be purchased. Recently, LED is used for many products, and then those are very strong and then durable for a long time. Oop. Can you see this? This is a very good idea, and I was surprised to see this. this is for teaching purpose. One side is a student, the other side is a doctor. Someone created. Name is not recorded, but someone created that kind of things. I think this is very effective. During my student time, I wanted to listen directly to the heart sound of the different types of patients, but it was not so easy. But using this, a cardiologist can explain during the Auskultation is a German word. Is it correct? Auskultation, yeah, sure. That kind of idea, we can make it. So, ladies and gentlemen, I have 3 messages. Timely investment to health facility is mandatory. I think the entire government, in collaboration with the international and domestic partners, we have to do this investment in order to allow the innovations come inside the routine work. Then technology, technical innovation and managerial innovation should be recognized by us. The second message is innovation itself cannot be sustainable without a favorable work environment and work system. Let's continue 5S and Kaizen for that particular purpose. The last one, frugal innovation. We have to have a creative mindset, then try to do something for the betterment of the safety and quality of the service by giving our idea and practice for innovative things. I think this is mandatory for us. Every day, a day for learning. Every week, we do something. Every month, we have to make a quick review, and then we continue to seek perfection even under given circumstances. I think we can do that. Uganda should be a model for that for the entire African continent. Thank you very much for your attention.
Thank you so much, Professor, for that very interesting presentation. You have given us good learning of how the 5S Kaizen can be, and the most important thing is that we can be able to innovate small from wherever we are working. We can be able to innovate. We shall have the level of discussion, but let me take this opportunity to invite our second presenter this morning. Our second presenter this morning is Dr. Esther Karamagi. She's a program management specialist at USAID. Dr. Karamagi has worked as a chief of party for the long time. Most of the years I've known her. I think immediately we left medical school, it seems like she went into quality improvement systems, and most of the time she has been working through that. And I just want to take this opportunity to invite Dr. Karamagi Esther to come and share with us. Thank you.
Good morning. Okay. Yes, so as our chair has said, I'm called Dr. Esther Karamagi Nkolo, and I'm making this presentation to you based on some work done by the Harvard School of Public Health, so I'd like to acknowledge them from the start. I hope I can work this. Okay, so I'm going to be talking about how to achieve a high-quality health system, and I'll start by defining it. This is based on the Lancet definition, which was released in 2018 through a Global Health Commission on High-Quality Health Systems, and this has given rise to a movement across the world to build the quality of health systems based on this definition. So a high-quality health system is one that improves health. This is what we know, reduces maternal mortality and so on. But in addition to that, it should generate confidence in the people and also have economic benefits. So confidence is about what people think about the current health system. And I think Professor Handa, this is what he meant when he talked of happier people. So people should be healthy, but they should also be happier. So this is what we are talking about going forward, at least through the Lancet Global Commission, as a definition for high-quality health systems. And it's been already started to roll out in about 14 countries, including our neighbors, Ethiopia, Kenya. So I'm hoping that by the end of my presentation, we'll have a good sense of what this is, and we can start this in Uganda. So why are we interested in a high-quality health system? Where do I point the pointer? Okay. So according to the data we have from the low and middle income countries, 7 million deaths are preventable, and 8.6 million are amenable to the health system. This means that the health system can eliminate these deaths. For example, a death during surgery is considered amenable, while a death due to lung cancer or anything outside of the health system is considered preventable. So I'll use this term a lot, and it's used a lot these days. So there are deaths that are due to, that our health system could have stopped. Those are the amenable deaths. So of the 8.6 amenable deaths in low and middle income countries, 5 million, which is about 60%, are due to poor quality health system. And the rest are due to non-utilization. That's people reach the health system and they still die. If a mother comes to us for antenatal and then we don't detect that they will need a cesarean section and they die, that is a poor quality health system. So it's not so much an access issue, but more of the quality of the health system that exists currently. The rest of my presentation is going to be about these 5 million people. So I'll start by introducing this framework. If you do a Google search, you'll find it. It's just a new way of looking at high-quality health systems. You can see at the bottom is the health system building blocks we know, and these are, consider them inputs in the quality language. These need to be there, and I think we said that a lot yesterday. We focused a lot on these building blocks. They need to be there, but after the building blocks are there at a national level or district level, we then need processes of care, and then we get quality impacts. So this is something that's not so unique to the front line, but what we are saying now is that even at national level, even at regional level and at district level, we want to look at this framework like this. It is a people-centered framework. It's for the people, and therefore you'll see a lot of focus on the people. The top right, you see that triad that is very important. It's talking again about the definition: better health, confidence in the health system for the people, and also economic benefit. So we should not forget that everything we do in the health system is for people. They should be better and they should benefit from it. So I'll come back to this framework several times. Don't worry about cramming it. I'll start with how do we measure, because as you know, in quality you can't improve anything you can't measure. I'll start with this process side. So the lower part about the building blocks, I assume we know that, but I'll stay with the upper two pieces, which are probably a bit vague for some of us. So for processes of care, there are two pieces. There's the competent care, competent system, and then we have the positive user experience. Some of these might be familiar to you, but I think what we want to do is to start looking at them in a way that's useful. So for competent care, this is about the quality of technical care. And I think also Professor Handa said this. People should get the right diagnosis. They should get the right treatment. So we need to have data that tells us these things. Is the care competent? Are we doing the right, referring the right people? That's just a basic. So we can't be doing pieces of it. We need to look at the whole framework. So for competent system, it's more about the broader system and how it's organized to ensure functionality and continuity and that the patients are benefiting. I'll share some examples to drive these points home. So look at the y-axis of this graph. I hope it's not too small. There are some common health services in our system. The reddish dots are high-income countries. Wherever you see red dots, those are high-income countries. This work I'm sharing, by the way, applies to all countries, high, middle, and low income. It's been rolled out in the European zone through WHO Euro, and in some of our countries using Bill and Melinda Gates funds. So that the red dots are high-income countries, and some of the data I'll share will be from high-income countries. You can see that all countries, regardless of the income status, give about 50% of the recommended clinical action for each of these services. So it hovers around 50%. This data is from one of the reports of the Lancet Global Commission. So we have the knowledge. We have put it in different policies and guidelines. This is typical for our country. But what proportion of the recommended actions are performed by health providers in our system? This, I don't expect Uganda to be very different. We are probably around 50%. So we need to understand and close this category of quality problems. This is about correct treatment, the first part. So I'll now share example on competent systems. This is about continuity. Here I show measurement of continuity of care for competent systems. We already use this for HIV, TB, and several chronic diseases. The number of patients dropped as you progress along a cascade will tell you how competent your system is. On the top left cascade, you see that only 26% of the patients with diabetes have controlled diabetes in Thailand. This tells you that the system is dropping 74% along the way. Is this a high quality health system? Do we know how we are doing for our country? I know you have these cascades for the HIV 95, 95, 95, and so you can check these, but look at it for your facility, your district. Don't only wait for the Joint Review Mission and so on to tell these things. We need to see this quality data at all our levels. So the progress acronym you see on the side is a good way to remember to cover the different categories of patients. You want to see cascades for different gender, different ethnicity, different geographical locations, and so on, because you might look like at aggregate level you're covering everyone, but we've said this high quality care is people-centered, so you'll find there are some who are left behind. So that's an example of competent system. So I'll now share about user experience. I think we have this thing disturbed. Yes, we have a lot more experience with user experience. It's a process measure. When you see people talking about feedback at the front line, we had a lot of that presentation yesterday. Consider that a process. We want to know the preferences, expectations, needs of active users of the health system, while reducing unnecessary burdens on the system. So we don't want to address user experience while we are worsening things for health providers. So that we should balance. The department, the SCAP department, has multiple tools for, we have annual patient satisfaction surveys and so on. Take interest in those for your district. How is this looking at your district, at your region, and so on. So the problem we are facing is to operationalize these types of data for patient user experience. We need to change data tools and institutionalize it. We shouldn't be just doing it as one-off surveys and things like that. So hopefully we can, and I know the department has started to work on that. So hopefully you'll start to see more of that in the coming year as routine M&E data for provider user experience. Well, this thing doesn't like me. Okay, so, so this is an example which I'm trying to project here of results from user experience about the red dots again are high income. Red dots are always high income. In this case, you see that patients in high income countries get better user experience than patients in low and middle income countries, where about 30% of our patients get disrespectful care, short consultations, poor communication, or long waiting time. So this one, there's a bit of a problem on our side. Okay, so I've shown you a lot, or some examples